This is one of the most important personal injury topics, and especially in a deposition or trial testimony. Now, it does need to be in the narrative report, but unfortunately, this comes in essentially a copy and paste format. So I give not this particular sheet you're getting ready to see, but I do have a copy and paste format that is paragraph form. But basically, what it does is explains pain and explains sources of pain. It explains why somebody can have pain while they're stationary, why somebody can have no pain at all while they're stationary in the neutral position, or even if they move 10, 20, 30, 40, 50 degrees, but they only have pain maybe at the end of that range of motion, or only in overpressure, or they have no pain at all in any of the range of motion, but they have it in one plane of motion in overpressure. Okay. So you've got to have a kind of a good concept of this. So let's walk through this specifically and go into this, but you definitely need to do this. And by the way, it needs to be brought up in a deposition or trial testimony, and that's part of our line of questions. It has to be brought up before the defense says anything about it. In other words, and here's why. You've got to account for it, and this is why I say, especially in a not as much of a deposition, but a trial testimony. But you've got to explain why this person, like let's say to a jury, they look across the room and this person looks normal. They're not in a cast, they're not on a gurney, they're not in a cervical collar, they just kind of look, and the person's kind of moving around. You've got to be able to explain that. Or, it's hard to overcome that if you don't explain it. And you have to address it, period. And you want to address it before they bring it up. This is why it's one of the preemptive strike questions. So let's go into, and basically it involves three categories. It's not just pain. It's why the person is more susceptible to re-injury and stiffness. So in other words, why does the person have pain in some ranges of motion and not other? Why do they have pain with no movement at all? Why do they have, what causes re-exacerbations? And what causes the stiffness and rigidity of the patient? That's like major in personal injury. Okay, so let's walk through the categories, and we're just going to simplify it and dumb it down if you kind of think about it in these categories. So let's walk through it and then simplify the heck out of it, okay? But you got to know all of those categories I just referenced. Okay, so here we go. So all injuries go through the signs of three phases of healing. Of course, you know that, the inflammation, repair, remodel phase. Major points in the three phases of healing. So each of the three phases of healing is physiologically different. The goal of the therapeutics is to restore the specific physiology of each phase. And if the healing occurs abnormal, the patient will suffer a permanent injury to some degree. And remember, and I go into great detail about subthreshold injuries that, no injuries heal 100%. And I'm not going to get into it too much here. I just want to remind you, no injuries heal 100% normal, period. That's type 3. Remember, you're born with type 1 collagen and you heal with type 3 that has these lesser quality physiological factors. But they're subthreshold. So, and of course, that's what you're trying to do physiologically, is take all of these physiological goals to subthreshold. What does that mean, subthreshold? It means that it's not affecting any of the patient's sensory or motor factors. So you can definitely have a permanent injury, but it's subthreshold. Doesn't affect your range of motion, doesn't affect sensory, nerves, nothing. So, okay, and it's the ones that heal abnormal above threshold. That's what matters. And then, of course, the goal is to quantify. The first goal is obviously to get them all non-subthreshold. But when somebody heals abnormally, the goal is to document which of the threshold categories are involved and to quantify it. That's the goal. And then be able to explain it. Why is it that that person has a limitation in this plane of motion? Or why do they have pain only at the last 10 degrees of that plane of motion? Okay. Okay. So this is like 101 personal injury. This is nuts and bolts. Okay. So each healthy joint has 3 ranges of motion. So of course you got the active. That's how far the patient can move on their own. Now this is going to be the reason I'm setting this precedent is this is going to become really important to be able to explain why somebody does or does not have pain with in neutral position, no motion, or with the activities of daily living. And remember, that's the 1-2 punch of personal injury. Is there a permanent injury? And does it cause pain and restrictions with ADLs? Pain and restrictions with activities of daily living. So this is where this category fits in. You've got to be aware and know how to explain it. Okay, so active range of motion. So it's how far the patient can move on their own. Overpressure requires an external force. Okay, it goes past active range of motion and ends before joint motion. Exterior forces such as pushing, pulling, lifting can take joints into overpressure. Now that's real important what we just said. So an external force is not just therapy, a therapist doing therapy, because that's therapy. But it's when patients do things, and this is real common, when they push something that can take them into overpressure, when they pull something, when they lift something. See, all of these can take that patient into the overpressure range of motion. And by the way, that's why it's real common, not real common, but sometimes you can have no pain at all, and then you lift something and it hurts. That's pulling. Okay, so, but we're going to go into why, and you've got to be able to explain that. And by the way, the attorneys love it because they don't have anybody that knows this. They don't have basically, they don't have doctors that can document it very well. And they definitely don't have somebody that can explain it. Okay, so this is for you to be able to explain this to an attorney is gold. It's very valuable. Okay, then there's joint motion. So after active range of motion and overpressure motion is joint motion. Joint motion is the most important because it's the fulcrum of all motion. All ranges of motion start with joint motion. So that's why the therapeutics in the joint motion are so important. Because as soon as you affect the joint motion, you significantly increase active and overpressure range of motion. And if you think about it, you can look at draw a line, and then right at the center of the line, move in a circle, draw a line in the center of the circle. There's a point, and the line goes out. Move that line 1 millimeter at the center, and then go to the outer limits of that line, depending on how far you go, how much further motion it's going to be. So, and a good example is like if you're looking at human anatomy, and let's look at the head as an example, and we're looking downward on the head, and we look at its instantaneous axis of rotation, the center point. In other words, when somebody turns their head to the left or to the right. And so let's say they can turn their head to the right a certain amount. Let's say they can go maybe, let's say 40 degrees. And you measure, now let's look at the center point. And let's say you move that center point 1 millimeter, only 1 millimeter, because when we do adjustments, that's what's happening. It's only moving a few millimeters. So let's say you move it 1 millimeter, but let's go out to the nose. So when you turn the head and they're stuck at 40 degrees, now move the center point, the instantaneous axis of rotation, 1 millimeter, and let's say it's to the right. Now come out to the outermost part, which would be the end of the nose. Did the end of the nose move only 1 millimeter in degrees? No. It moves significantly. It could have moved 5 degrees. It could have moved 4, 5, 6, 7 degrees, even 10 degrees. See, the further out you go, the more movement occurs. Okay. All right. So this, just basic biomechanics here. All right. So now the four most common factors. And by the way, let me just point this out to you. If you're dealing with athletics and you're dealing with athletes, this is one of the reasons that chiropractic is so beneficial to athletes, because if they knew this, if athletes knew that they could get their joints adjusted, and then the of course the joint itself, the joint motion would only be 1 to 3 millimeters, but how it would affect that athlete's mobility. And using the example that I just gave, if that was a wide receiver, for an example, and they could only turn their head 40 degrees, and then after you adjusted them, they could now turn it 50 degrees. That gets to be real important when they're turning backwards, looking for that pass from the quarterback over the shoulder. See, all the different extreme motions that athletes use increase. That's just a side note, by the way. Okay, so let's go down here to four most common factors. Patients. So these are the four most common factors. Patients heal wrong or suffer permanent injury to some degree. So what would be the reasons why patients would suffer permanent problems? Well, age. We don't heal as well as we age. There's more type 3 collagen. We have all these micro traumas that are subthreshold over, over 30, 40, 50, 60 years. They're subthreshold. They're the repetitive micro traumas. So individually, none of them affect sensory or motor at all. Well, 40 years later, you can't move as well. That's because those micro traumas, and I always call it, it's like a real good, easy way to think of it is like layers on an onion. Well, the layers increase with those, that type 3 scar tissue is another layer, and it just increases. Well, if it's subthreshold, it doesn't matter. It's not going to affect your sensory or motor or your mobility, nothing. But eventually it does. Eventually, those layers start increasing to where now it starts to affect you. And then remember, what does it start to affect first? Joint motion first. That's the first motion that always starts to be affected first. And then as that deteriorates, it starts eating into overpressure. And then as that deteriorates, it starts eating into the end of active range of motion. And then as that starts to continue to deteriorate, then it goes from outer active range of motion, it starts to deteriorate in toward. So that's why when you're young, you can move everywhere and anywhere. And then as these micro traumas accumulate over time, they're subthreshold, and then they get to be threshold, just from time alone, not just from any particular injury. And next thing you know, you're stiff and rigid, and you don't even have normal range of motion anymore. That's why it just kept eating into it over time. Okay, so permanent problems associated with each phase of healing when we heal wrong and what it means to the patient. So these are permanent problems. So the inflammation phase, abnormal healing from chronic irritation. Patient's permanent problem, pain and chronic inflammation in all three ranges of motion. So if the person has abnormal healing in the inflammation phase, that's called chronic inflammatory disease. You've heard that before. Chronic inflammatory disease. Patients, they have pain and chronic inflammation in any and or all three ranges of motion. Usually chronic inflammatory disease is from repetitive microtraumas. What's the most common repetitive microtrauma? Carpal tunnel. Repetitive motion in the wrist, usually work-related. Carpal tunnel. What's number 2? Back pain. That's the number 1 and number 2 workers' compensation injury right there. It's from repetitive trauma, not micro trauma. Okay, so you go to the repair phase, abnormal healing, increased nerve sensitivity, a patient's permanent problem, pain with any or all three ranges of motion, least compressive pressure. And now this is going to be real important as we talk about nerves. We're going to pay a lot of attention to tensile pressure, tensile forces, and compressive forces. In other words, when you move, you move your elbow, your spine, your neck, your back. So tensile is pulling and compression is compression. So we're going to pay a lot of attention to tensile and compressive forces as sources of pain relative to movement. And so, okay, so let's go into this. Patient's permanent problem with pain. So if least compressive pressure is an active range of motion. So when there's active range of motion only, how much tensile or compressive forces in there? Tensile, not much. Now remember, we're not talking about lifting weights. Lift weights, that's a different animal. But for you to just move your head, bend your elbow, that's an active range of motion. How much tensile forces are there? Very little. How much compressive forces are there? Very little. This is going to be important in being able to explain pain. Okay, abnormal healing. So if there's an increase in the number of nerves, so what can cause it? Patients with permanent problem, pain in any of the three. So remember, and we'll go into there's about 6 sources of pain. So let's cover this and we'll go into the 6 sources of pain and how they relate to tensile and compressive forces relative to the science of the 3 phases of healing and collagen. Okay, so abnormal healing. So if there's obviously an increase in the number of nerves, patients, what could happen with the permanent problem? Pain with any of the 3 main ranges of motion. Well, why? What's happening to the tensile or compressive forces? So the least compressive force is active range of motion. The most pressure is overpressure or joint motion. That's the most, okay? Now, that's going to be real important here in just a second. So abnormal healing, see, if the nerves get trapped in the new collagen, type 3 collagen, or scar tissue, patients with a permanent problem. So the pain can be in any of the 3 ranges of motion. That's good. In other words, those nerves could be trapped in joint motion only. And that's the only time you'd feel the pain. Or they could be involved, and again, we're talking about compressive tensile forces. So it could be the quantity or quality of nerve fibers that are entrapped, as well as the amount of tensile or compressive forces. All of those are relative factors producing pain. So the least compressive pressure, again, is active range of motion. Most pressure is overpressure. That's why you'll always typically feel more pain with a permanent injury in overpressure, or why you'll only feel it in joint motion overpressure before anything in active range of motion. So you go to the remodel phase, abnormal healing. The new collagen formation forms a non-striated matrix, only 70-75% is strong. Patients with permanent problem. This is the source of re-injuries. When there's type 3 collagen that's only 70-75% as strong as the original collagen, that's the source of re-injuries. So the least strain is an active range of motion. Most strain is overpressure joint. So remember that. That's a major concept. So abnormal healing. So the new collagen formation is only 75% as elastic. So 70. And by the way, and hopefully you know this by now, when I say 70%, 5%, you're not going to see a research journal that says 75%. You'll see 60%. You'll see ranges, 80%. We give a number like 75 to make it easy to understand. So you can see a range of tissue that's affected from 40, 50% to as little as 80%. So just be aware, we're paying attention to the bell curve of these problems. And we're doing it for communication, ease of communication purposes. It's easier for me to say 75% or 70% elastic as opposed to, well, it could be from 60% or it can get up to 80%, so that's why. Okay, so it can be more than 75%. It can be less also. Okay. All right. When patients perform activities of daily living, they go through each of the three phases, each of the three ranges of motion to some degree, depending on the activity. Okay. So active range of motion, overpressure, joint motion. And, the classic example and it says each of the three ranges of motion have different tensile and compressive forces. And that's the key. So we're getting ready to go right into the key of being able to explain this. Now, the story that I tell relative to this is, if you remember the first big case that I personally, the case that I had that put me on the map is when I took a case that went from 0 to 100. I took a case from 0 to $110,000 policy limit, and it was against two medical doctors that said she was totally normal. Well, she had normal active range of motion, and I agreed with the medical doctors. The medical doctors did not measure overpressure range of motion, and they did not measure joint motion. I did. I measured it with fixation, overpressure, tenderness, and the x-rays. And it was and then we connected all of those, but the one that was easiest to see obviously was the x-rays. But I supported it with the other biomarkers. With fixation, well, the jury couldn't see a fixation. I had to explain it. And then, well, excuse me, they could see it when I showed it on the x-ray. Or the tenderness with a fixation, they couldn't relate to that. They couldn't see that. Okay, so that's when we showed them motion x-rays, and we showed how the active range of motion was totally normal. The intersegmental motion was totally pathological. It was very easy to see. And so I explained it relative to the mechanism of injury, the other associated collaborative findings, in other words, symptoms. Did they have symptoms that were directly related to those motor units? Yes. Back pain. Hybrid findings. Did they have hybrid findings directly related to those motor? Yes. Palpation, fixation, tenderness. Did they have objective range of motion tied direct? Yes. Motion x-rays, it was very easy to not only see, but to quantify and measure. The medical doctors didn't do any of it. And then I was able to explain why she had no pain in active range of motion, but she could not pick up a laundry basket because the laundry basket took her into overpressure, flexion overpressure. And that's also why she could not pick up her 6-year-old child. It took her into overpressure. And then, of course, I related that right back to the science of the three phases of the healing, the nerves and the collagen tissue, which we're going to do right now. Okay, so specifically, we're going to pay a lot of attention to tensile and compressive forces. So when you move, so the higher the tissue tensile and compressive forces, it's the greatest likelihood of nerve irritation or compression, collagen tension or compression forces. So that's what you want to think of. Look at the tissue in a confined area. Think of compression. What's happening to the compression when that patient moves with activities of daily living? And what's happening to the tensile forces of that tissue when the patient moves relative to that activity of daily living? So the tensile and compressive forces will determine the potential nerve irritation or compression, collagen failure, or collagen elasticity. So we've got to be aware of three major categories, right? Pain. Why does the patient have pain or no pain? In neutral or non-neutral, and what range of motion? Why? And then we have to pay attention to the strength of the tissue and the elasticity of the tissue. So we got to be able to explain that. Okay, so here we go. So we're going to the three ranges of motion relative to tensile and compressive forces. So, see, we got several variables that we got to consider here. So active motion, how much tensile forces are in active range of motion? It's low. Now, remember, we're talking about not putting any forces in there. You just, moving your head, bending your arm, that's active range of motion, okay? So how much tensile forces are there? Tensile meaning pulling. Not much. How much compressive force? Not much. Okay. Now, what happens when we move further? What happens to the tensile forces when we move into overpressure? What increases? Now you go into high tensile forces. What happens to the compressive forces? It significantly increases. Now, you could say, let's say moving the head, for example, inflection. You could say when you start moving the head the first, 5-10 degrees, there's very little tensile or compressive forces. And then the further you move it, what's happening to the tensile and compressive forces in the anterior and posterior component areas of the neck? They're increasing. Now, what happens when you get to the end of active range of motion and you go into overpressure? They significantly increase, not just a little, they significantly increase. Because remember, the patient can't do that on their own. You have to move them in overpressure. Well, how much tensile force does that take? It takes a lot. They can't do it on their own. How much compressive? It's potentially a lot. Now, how does this relate to pain or restrictions? Let's just keep moving. And then what about joint motion? How much tensile forces? And there's tremendous. When you give an osseous adjustment, how much force do you got to get way more force than if the person was just moving an active range of motion 10 degrees. Okay. So these factors, we got to know these because we're going to apply these to the 6 categories of nerves. Active, so we're going to pay attention to active range of motion, overpressure, joint motion. We're going to look at the potential of tensile or compressive forces in each one of these ranges of motion. And then we're going to apply the 6 different categories of potential nerve pain. And that's how we're going to explain if the patient does or doesn't have pain and when they have pain and why they do or do not, why the pain increases or why they have no pain. See, that's what you have to be able to explain. Why is there no pain when they're in the neutral position? Why is there chronic low-grade pain in their neutral position? Why does the pain increase when they start to move? Why is there no pain when they move a little bit and they only feel pain when at the end of active range of motion? Or why do they feel no pain at all in neutral position or active range of motion, but when they go to do something like activities of daily living, it causes pain? Well, then it takes them into overpressure range of motion. So now we have to combine this with the categories of nerve. So the 4 main reasons why patients have permanent injury have pain-free full active motion or painful restricted overpressure motion or joint motion during activities of daily living. Active motion is the least potential tensile forces. Active motion is the least potential compressive forces. Active motion is the least potential for strength testing. Active motion is the least potential for tissue elasticity. In other words, now we looked at 3 factors here. Number 1 and 2 had to do with the nerves. Number 3 has to do with the collagen, type 3, the strength of the type 3 collagen. Active motion is the least potential for strength testing. So you're going to have the less likelihood of finding a strength issue with active range of motion. And then when we go with tissue elasticity, again, that's the elasticity of type 3 collagen. It's the least engaged in active range of motion. What does that mean? The patient won't feel, the likelihood of them feeling something is less in active range of motion. Why? Because there's not as much compressive or tensile forces. That's why. That's why they won't have as much strength weakness or as much mobility in the active range of motion category. Okay. This is the gold. This is how it all comes together right here. So you go, what are the sources of type nerve? So we go type A and type C nerve pain, okay? So let's pay attention to that first. First of all, we got the autonomic versus the peripheral nerves, right? So, in real simplistic terms, when I'm in a jury giving a testimony or talking to an attorney, I go, well, you have the your central nervous system that goes to your peripheral nerves. And then you have your autonomic nervous system divided into two categories. Basically, it's start, stop, or on, off. That's how easily I explain it. And in other words, it tells the tissue to work better or to not work at all. That's start, stop. That's the autonomic. That's the sympathetic, parasympathetic. So that's how much I dumb it down to attorneys and to juries. That's how I explain the autonomic nervous system, sympathetic and parasympathetic. They go into the organs, start, stop. Okay. All right. Then you have the peripheral nerves. You have type A and type C nerves, fast twitch, slow twitch nerve fibers. Type A are essentially with movement. Okay. So what are the sources of type A nerve pain? Well, they're psychogenic. So we're not going to play much role into that at all. What's the most common psychogenic nerve pain? Phantom limb pain. Phantom limb pain. Okay. Then there's inflammation. Well, what causes pain and inflammation? It's the difference of the pH balance. That's why we're trying to control inflammation. So in other words, it's a chemical change. Chemical. It doesn't have as much to do with tensile or compressive forces. It's chemical. Okay. Now, that's not going to relate as much to ADLs. Then there's direct nerve damage. So you have these injuries, and there's direct, in other words, there's physical nerve damage. The nerve gets compressed, bruised, whatever, okay? Direct nerve damage. So that's definitely a source of pain. The nerves getting trapped in the scar tissue, definitely a source of pain. Remember, this is called hyperinnervation, reinnervation. Increase in the number of nerves in that area. That's part of the science of the three phases of healing. When there's injured tissue, there's hyperinnervation, reinnervation. So there's an increase in the number of nerves, and those nerves have decreased sensitivity. Okay? All right. Now, how are we going to explain this? How are we going to put this together? Well, let's just talk about these first, and then let's go into the constant chronic or type C nerve pain fibers. Okay? So sources of type A nerve pain. Now remember, we're talking about a personal injury patient that's at MMI, right? So are we typically talking about psychogenic nerve pain? No. Are we typically going to be talking about inflammatory pain? In other words, from pH balance differences? No. Not typically. Okay. Direct nerve damage. Could be that nerve damage stays the way it is, becomes permanent. Nerves getting trapped in scar tissue. Okay. Now, how does this play a role in tensile or compressive forces? Okay. Well, you have the nerves that are trapped in scar tissue, and there's no movement. Let's say there's no movement. They're dormant. Okay. And let's say that's the only factor we're looking at right now. We're not looking at nerve damage. We're not looking at inflammation. We're not looking at any other category. We're only looking at this category and to be able to explain it. So nerves getting trapped in the scar tissue. So when the patient's in the neutral position, are they typically going to feel any pain? No. Are they typically going to feel any pain when they start to move in the active range of motion? Well, how much tensile forces are there in the beginning of active range of motion? Very little. So what's the likelihood of that scar tissue basically compressing those trapped nerves? Very little. What's the likelihood of the patient having pain? Very little to none. So they typically won't. Now, again, this will depend on the number of nerves and the number of nerves that are trapped. I mean, there's a lot of nerves that are trapped. It's not going to take as much movement, even though there's not much compressive or tensile forces. See, so there's several variables here we're paying attention to. But we're explaining to this attorney and to a jury why this patient. You see, because none of these patients are black and white. It's not like they always have pain or they don't have pain. You've got to be able to explain the different movements, neutral, active, passive joint motion, and relative to pain and why they do or do not have pain. What are the potential sources? This is it. This explains it. So, and I'll use the example that I used earlier about the patient of mine who, when she bent over, she had normal active range of motion with no pain. But when she bent over in flexion to pick up a laundry basket or a kid, she couldn't. It was painful. Okay. So now, when she first started moving, how much tensile forces? Not much. As her active range of motion increased in flexion, it increased a little. Did it increase a lot? No. What about the compressive forces? Well, the compressive forces increased, right? When you start contracting to flex, it increases compressive forces. So yeah, they started, the compression started, but is that relative to the nerves getting trapped in scar tissue? No. Mainly we're paying attention to the tensile forces with the nerves getting trapped in scar tissue. Okay. Now, when they go into overpressure, what happened to those nerves? What happened to the tensile pressure of those nerves getting trapped in scar tissue? Well, that scar tissue significantly tightened that matrix, and any of those nerves in there got squeezed. In other words, it's a physical pain from those nerves getting squeezed from being trapped in that collagen matrix. So certainly the patient's way more suspect to having pain in overpressure and range of motion, where they didn't have any pain possibly in active range of motion. See, I'm explaining this to a jury like this, to the attorney like this. This is gold to be able to explain this. Okay. What about joint motion? Well, how much tensile strength is there in joint motion? A lot. That's the most of a joint before there's re-injury. Most patients won't go into joint motion, though, with activities of daily living, right? They'll just go into active range of motion. Matter of fact, we already know they'll stop. If there's pain in overpressure, they won't go into overpressure. If there's pain at the end of active range of motion, they won't go into it. We won't go into it. We'll avoid the painful situation. So that's the nerves getting trapped. So there's definitely more tensile force compressing those nerves as the patient increases their active range of motion, and then it significantly goes up disproportionately in overpressure range of motion. And this is why patients almost will always have pain at MMI in the overpressure range of motion of the mechanism of injury. Next category is the increased number of nerves in that area. Okay, now let's look at a confined area, where, whatever area you want to look at, flexion, extension, whatever, okay? And we have an increase in number of the peripheral nerves in that area. That's called hyperinnervation, reinnervation. That's part of the science of the 3 phases of healing. Okay, so now we're going to pay attention to tensile and compressive forces. Let's use the same example, the patient bending forward to pick up a laundry basket. Now there's an increased number of nerves in the flexor tissue, okay? In the same confined area. Let's look at a confined area. Now, you have X amount of tensile forces in the beginning, not too strong again, right? What's happening to the compression? Compression is starting to increase quite a bit. So you can have a lot more compression forces before you have tensile forces in active range of motion. But as you increase your active range of motion, what's happening to the compressive forces? What happened to your muscles the more you contract a muscle? Go ahead and put your fingertips on your biceps with your arm extended, and then go ahead and slowly flex it all the way in. Look at the difference of compression of your biceps muscle when it was all the way in extension and relaxed versus all the way in flexion, active range of motion. Look how much more compression there is. Okay, so what's that compression doing to to an increased number of nerves in the same confined area? It's compressing them. That's a source of pain. So the amount of compression will be relative to increasing the pain, more compression. And of course, the more range of motion you go into, active overpressure, the compression forces increase with active range, and they significantly increase as soon as you go into overpressure range of motion. This is why the patient can have no pain at 5, 10, 20 degrees, 30 degrees, and then slowly start to feel pain, maybe the last 5, 10, or 15 degrees of active range of motion, and then they can't go into overpressure at all because it's too painful for them to do it. That's why compressive tensile forces relative to either the trapped nerves or an increased number of nerves in that tissue. Now, go to the number 6, decreased nerve sensitivity. Well, we know when these nerves, the new peripheral nerves come in, they have a lower pain threshold, meaning they fire quicker. So let's go ahead and apply this now to the same movement. Let's use the patient bending over to pick up a laundry basket. So they start to bend over. Is there much compression or tensile forces on the more sensitive nerves? No. So as they continue to move, what's happening to the compression and tensile forces? It's increasing. As it increases and combined with lower nerve firing, now the pain starts engaging more and more and more, dependent on what are some of the factors. The amount of tensile force, the amount of compression force, the degree of nerve sensitivity. Those would be the factors relative to when the patient would or not have enough pain to stop the movement of that activity of daily living. Okay, so we've got to be able to explain that. So essentially, we need to know this. We need to know the sources of pain, those 6 sources. We need to know active, passive, and joint motion. And we need to know tensile and compression and its relativeness to tensile or compressive forces and be able to explain it like what I just did. Okay. Now, again, we do have this in a copy and paste format, that you just dump into your narrative. But when you get in trial, you better be able to explain this to a jury. And it's great when you can explain it to the attorney. And of course, it will be in all your narrative reports why the patient does not have any pain in whether it's in a neutral or in some active range of motion, but they do have pain, maybe in the end of some of the active ranges of motion or whatever plane. And again, this is when you personalize it to that patient, and especially overpressure. And then you connect it to the activity of daily living. This is how I won that case. This was a main part of how I won that case. And then I supported it with mechanism of injury, a primary subjective findings, primary hybrid findings that directly correlate to what I'm talking about with that injured area, and then objective findings. In this case, it was the motor unit motion study, motor unit x-rays. And then I explained it based on the science of the 3 phases of healing relative to nerves. And that's how I was able to explain why the patient had no pain when she didn't move, or she had very little to no pain if she just, moved in active range of motion. But she definitely couldn't. She definitely had pain and enough pain to stop her from lifting a bag of laundry or her child that weighed 35 pounds. That took her into overpressure. You see how it all comes together? This is fantastic stuff. Now, the last part is the constant chronic pain or type C nerve pain. Well, how are you going to explain nerve? Now, that's motion. What I just explained was with motion. Type A nerve pain, the fast twitch nerve fibers, is with motion. That's how that's explained relative to the science of the 3 phases healing. Now, type C, what about the patient who has constant pain? Constant. With no motion, they feel low-grade pain. How are you going to explain that? Well, that's direct nerve damage to the C nerve fibers. That's what causes constant pain. Direct damage to the C nerve fibers. And by the way, this happened in the last case I was an expert witness in. I explained why he had first I explained why he had a low-grade constant neck pain. That was the type C nerve fibers that are damaged. And I explained the difference between, the autonomic nervous system, the peripheral nervous system, type A nerve fibers, type B, really basic 101 stuff. And then I went in, it was direct when he had the injury, that's the direct cause there. But why did he have pain in some areas of motion, but not others? That's when I explained the type A, the fast twitch that deals with motion. And I explained how these are the 6 sources of pain. And I specifically went through number 3, 4, 5, and 6. Direct nerve damage was the constant pain. And then 4, 5, and 6 was the nerves getting trapped in the scar tissue, the number of nerves in the area, and the decreased nerve sensitivity. And when you applied that to the compressive and tensile forces with his active, passive, and joint motion, that's why it caused more and more pain as he moved into a particular plane of motion. That was exactly how that was explained. And of course, we had all the background material to support it. We had mechanism of injury. We had a few injury magnifiers. We had primary subjective findings. In his case, it was constant dull neck pain with headaches. And then we had secondary findings. The most common secondary findings would be like a 3 range of motion orthopedic test, like foraminal compression in the neck, fixation, tenderness on fixation, and then the x-rays, and then the dynaram would help with the muscles. That's how all of this was put together to support this case and win. So we have to be able to explain. So this is what we want to connect. We want to connect the 3 ranges of motion, active, passive, and joint. Okay, we should have a good understanding of that. Then we should have a good understanding of tensile or compressive forces relative to movement, those 3 ranges of motion, and then plug in any of these 6 categories, specifically category 3, 4, 5, and 6, relative to type A nerve pain with increased or decreased active or tensile or compressive forces, or chronic low-grade constant neck pain. And there you have it. Now, that's how we explain the pain. Now, when we go over into the tissues, remember the tissues only, type 3 collagen is only 70% as strong. That's what accounts for the reexacerbations. And almost always you'll have patients with reexacerbations. When they feel good, they try to go back to do things fully, and they have a re-injury. That's why. And then you can explain lack of mobility, because that tissue is only 70% is elastic. Doesn't have the elastic tensile, elastic mobility physiological factors. So that's why they're more stiff, especially in joint motion or overpressure range of motion. And so this is why, and of course, all this is documented in your mechanism of injury, injury magnifiers, subjective, hybrid, and objective findings. And then it's documented in the activities of daily living, how it directly impacts, causes pain and restrictions with activities of daily living. This is the most important part, being able to connect your findings with the pain and restrictions with activities of daily living. That's what brings it alive. That's what brings the activities of daily living alive and real. And that's the second of the 2 most important factors of a personal injury case. Was there a permanent problem? And remember, that alone is essentially worthless unless it caused pain or restrictions with activities of daily living. You've got to be able to connect those 2 dots. Your findings to why was there pain or restrictions with those activities of daily livings. That's what we just did.